you guys have questions or comments or want to add something, want this to be more of a discussion than easy. Okay, so let's jump in. I want to cover a couple topics today. I want to start with just a basic overview of child life and what child life does here in our hospital, because I'm fairly new to the ED, a year and a half now, and what you see me do every day is like a sliver of what child life does across the hospital and in the profession in general. So I'm going to cover a quick couple slides on child life, then jump into our topic, which is fear and the developing brain. And I want to talk about children's experience of fear and anxiety at each developmental level, and follow that up with some strategies that you all can use here in the emergency department to help families cope with being in the hospital and improve the patient experience. Sound good? Yeah, okay, cool. I have a couple little handouts for those of you sitting here. This sort of follows the presentation I talked about earlier. Don't feel like you need to read all this right now, but it just, a takeaway for home for later. Okay, so who are child life specialists? We are trained professionals with expertise in child development. Most child life specialists have a master's degree in child development or education. At our hospital, it is required to have a master's. Most hospitals do require it now. We all have pretty rigorous training, which includes clinical internships and a practicum. And then all child life specialists are certified by the Association of Child Life Professionals, which is one national governing body that kind of keeps track of all our certification and all of our continuing ed, that sort of thing. Okay, what do we do? Our main goal is to promote effective coping for children and families. We do that through preparation and education, normalizing the hospital environment. That really looks like play, art, singing, dancing, that kind of thing, but it is a very helpful and a super important thing to do with children. And our goal is to just decrease negative impact of traumatic experiences. So most child life specialists work in hospitals, but you also see child life specialists work in funeral homes, dentist offices, pediatricians' offices, anywhere there's anywhere there could be traumatic experiences, you're now seeing child life specialists. They're being incorporated into quite a few different fields. Child life specialists work on disaster response teams across the world and go on trips like Operation Smile, those sort of things to promote coping. So anywhere you see trauma, you might see child life. The field has been in existence for about 60 years, and we've been incorporated into Children's Hospital Oakland for about 40, and in the ED for a year and a half, so we're getting there. Yep. Yes, it was a long time coming, but so happy that we're here now. All right, so at our hospital we have 12 full-time child life specialists, 3 part-time, 3 music therapists, 2 artists in residence, which are kind of like art therapists, 5 Oakland Unified School teachers, because we have a school room here at the hospital, and 2 Family Resource and Information Center staff. And all these kind of different specialties fall under the Child Life Services umbrella. Okay, we cover all the units in the hospital except for the NICU. We're called in for special circumstances, though, to the NICU. We cover outpatient surgery in the day hospital. And then we run all sorts of programming. We run the teen lounge. That's why I disappear on Thursday nights, because I run the teen lounge. That's open every night for teens. We do all sorts of fun activities. We run the playrooms. We run the music groups, parent relaxation groups, all the animal visits to the hospital. I don't know if you guys know that we have miniature horses that visit the hospital every other Wednesday. It's so fun. They're so cute.
They visit us?
Right? They're in the courtyard.
Stacy would love that.
I do. Oh no, I love
so
those horses.
Cute. They're the
so
cutest.
cute.
So I'll let you know next time they're here. 1 to 2 on every other Wednesday in the courtyard. They're so cute. We used to have pet therapy, like dog visits. That is we're taking a break. We're working on infection control on that official policy, but they will be back soon. We have dogs that visit bedside, which is really neat, once a week. We run the bingo here in the hospital every Thursday, which is super fun, and all the art groups. We also all the special events and the holidays too. So Christmas time, I'm in charge of the winter holidays, so I do Christmas and all the associated winter holidays. So the week before Christmas, I'm sort of non-existent in the bedside setting, but I'm running our holiday store, making sure the Christmas morning presents are delivered, make sure Santa's set up, make sure all those things are in place so kiddos can have a semi-normal Christmas experience here in the hospital. We also do special events like prom, we have hospital prom, we do all the special visitors. We have a couple really neat ones coming up. I'm taking 36 patients to the Dreamforce concert next Tuesday night, which is really cool. So just little things like that. Foundation reaches out to Child Life to find patients for events. That sort of thing is all done through Child Life. So you see me do all the bedside stuff here in the ED, but our scope is pretty broad. All right, so let's jump into our topic for today. Any questions on Child Life or what we do or where we are or anything like that? Okay, cool. So I want to talk about fear today. Fear and anxiety. I threw anxiety in there a little bit, which is sort of a separate topic, but they're closely related. So this child is definitely experiencing some fear. He looks quite scared. Fear is an unpleasant emotion caused by the belief that someone or something is dangerous, likely to cause pain, or is a threat. So I got a quick clip here. That's about it. Whoa. Let me turn the volume up. One sec. Volume. What's the volume on this one? I'll replay it, guys.
Click on the little speaker button on the bottom.
Yeah.
Can you put on it?
That's what I think.
Okay. I haven't seen this movie yet.
There you go.
Oh, it's
You haven't seen it? But you have
You should be ashamed
to.
of yourself.
It's so good.
My 3-year-old, I guess.
Yes.
Someone heard it.
How colorful it is.
Okay. Let me just.
It's a must-see Pixar.
There you go. Bottom right.
Oh, it's all the way up. Ah, okay, well, folks, that might not be the best, but, sorry, y'all. So that might not work today. I have a couple other clips too.
Know how to project sound
Yeah.
in here.
Right.
You can project it in the other rooms.
Okay, well, that's right. So that was a little clip from the movie Inside Out. Have you guys seen that? It's super cute. So that's what fear looks like inside the brain. That little creature was fear, and he totally overreacts to this movie that this little girl is watching, and everyone else is like, chill, chill, chill. All the other emotions are trying to figure it out, and fear just can't handle it. It's too scary. So that's fear. Okay, moving on now. All right, just define anxiety real quick. It's a state of worry, nervousness, or unease, typically about an imminent event or something with an uncertain outcome involving physiological arousal, but often without organized functional behavior. So a little different. It's more of a general state than fear. Fear is usually a more acute stress response. Anxiety is more long-lasting and often just more of a general state of being. So, fear and anxiety at each developmental level. Okay, you might recognize some faces here. This is my little guy, Jack. He is 8 months old now. So at the infant level, 0 to 12 is quite a large amount of time in the development world. We see a lot happening here, but I'm going to be kind of general about my explanations. So we're seeing a lot of sensory curiosity, a lot of neuronal connections being made, pruning, a lot of myelination happening. The brain is really getting going. They're figuring out their world. A lot of object permanence develops in this time. We see development of language, and then coordination of sensory and motor responses. And does anyone remember, thinking back to your child development classes, or maybe neuroscience classes, what stage in Erickson's stage infants are in? Does anyone recall?
Yeah.
4 bubbles or stickers. Does anyone remember? Infants. I'll start you off. The first one is trust versus
Mistrust.
You got it, Brian. Nice. Close enough.
No, autonomy versus shame.
That's a good one too. That's next.
But that's next.
So our infants are trying to, they're building trusting relationships. They need constant and really reliable care and affection for proper brain development and to develop those trusting relationships in their life, which is important in the hospital setting. And I'm gonna list some common things that cause fear amongst this age group, and there are obviously many, but this is gonna focus on what could cause fear in a hospital setting. So that's this little hospital specific. But first one, separation from caregivers. Being over or understimulated. Overstimulation happens a lot here in the hospital setting. Understimulation if they're laying in the bed by themselves all day long up on the units, we see that too. Loss of regular routine, which is a very common hospital side effect of hospitalization for infants, and strangers. So all things that we see here every day, our infants are faced with every day, cause fear. I will talk a little bit about the kind of fear pathways and reactions in a second, but I'm just going to go through each age group first. Any questions on our infants? Okay. So toddlers, you guys recognize this little guy? That's Kim Ross.
Oh, that's right.
Yeah, so toddler group, 1 to 3 years old generally. We see the beginning of symbolic thought and symbolic play, which is very important as they're developing their schemas of the world and how things work. The development of more appropriate syntax and language. They definitely can understand, so their receptive language is much higher than their expressive, but they're understanding a lot of what's being said around them. Their imagination starts running wild, which is a good and a bad thing sometimes. They're very literal, concrete thinkers, and they start to experience feelings like shame and failure. So not only all the happy emotions that you see toddlers experience, but also some tough ones too. An example of a concrete 3-year-old thinker, my neighbor's son was dressed up like Batman for Halloween, and was going door to door, and one of our other neighbors opened the door and said, "Who are you?" And he said, "I'm Nathan." And he meant, "Who are you supposed to be?" But like to this 3-year-old, who are you means, "Who are you?" And he said, "Nathan." So not able to think more abstractly like we see later on in our school age and adolescent population. So what are our toddlers scared of in the hospital? Separation from caregivers, this is a big one, and this group will let us know that they're not happy, as you all know, so keeping them with their caregivers is super important. The dark, also a very scary thing. Unfamiliar environments and equipment. Not having opportunities for play. Losing control or autonomy, and being restrained. So all super scary to our toddlers. All things that happen here all the time. Preschool, look familiar? Yes. Okay. So our preschool group, these are our magical thinkers. They are pretty egocentric. Their world is their world, and that's all that exists. And they have pretty extensive language development at this point. They're really trying to find their place in the world. So they're watching relationships happen. They're learning a lot about their relationships with their teachers, with their parents, with peers, and amongst peer-to-peer reactions at school. They're really figuring out how things work in the world. And they are very afraid of longer separations with caregivers. So they might handle, a half-day preschool, that sort of thing, but any longer gets a little tricky. Unfamiliar procedures and equipment. Not knowing what to expect. Anticipated pain. This group knows what pain is, and they've experienced pain before, and they know what causes pain, and they're afraid of it.
They're afraid of scrubs.
Scrubs, that's a good one too.
Yeah.
I love that. Yep, that's a good point. So things that they might associate with pain. Exactly. This was a kind of a cool quote I found. This comes from Thompson & Thompson. This is our Child Life Handbook. And it says, a combination of magical thinking and egotism means preschoolers make up meanings for things they don't understand. And this is something that we see as child life specialists all the time. And this is an example. Painful procedures are punishment for an earlier behavior. So oftentimes if you ask a child, a preschooler, why did you have to have that blood draw? Parents might be saying, oh, because you're sick, because we're at the hospital, but they might say, because I pushed my little brother this morning and now I'm in trouble. Things like that. So they are associating, they're trying to put meaning to all that's happening, and they don't understand, if they don't understand why it's happening. So important to know when you're explaining things to little ones or explaining things to parents. You can let parents know they might not understand why we're doing this, so if you can continue to tell them that we're trying to make them feel better, that sort of thing, because they will place meaning and sometimes it's really incorrect, which leads to a whole slew of poor coping down the line. This is also important, we see this a lot with siblings. So if a sibling comes in and maybe receives a new diagnosis of leukemia or diabetes, a sibling might say, I caused this because I pushed them. Or I caused this because I'm mean to my little brother sometimes. So there's misconceptions happening across the board, especially in this preschool group. So when we're doing our child life preparations and our child life explanations, we're digging down to figuring out not only preparing the child, but what do they understand and why do they think it's happening. So our school agers are a really cool group, a ton of brain development. They're in the Links kids and what have you. And we are seeing a lot of rational thought happening here. So they're understanding cause and effect relationship a bit more. Their prefrontal cortex is becoming more mature. And they have an improved understanding of time and space, which is important for the nursing staff to know, because when we're explaining this breathing treatment is going to run for 30 minutes, if you say that to a preschooler or a toddler, no clue. No clue what 30 minutes means. That is a hard thing to conceptualize for them, but a school ager is going to understand that. The younger kids, you can relate it to something like, this is going to be the length of one Dora show or one Clifford show. Whereas you get a little older, then you can use the clock on the wall. This is going to be 30 minutes, so when the hand reaches the 6, it's going to be all done, that sort of thing. And then closer to the 10, 11-year-old age, obviously they know 30 minutes is 30 minutes. So this is important when you're thinking about explaining things as far as length of procedure. Our school agers are afraid of losing control because now they figure out that they have control of a lot of their world, and they're afraid to lose that. This group is pretty afraid of injury, illness, death, and disability. They have a much better understanding of death and what disabilities can be or what they are caused by, and are very fearful of them. A general fear of inferiority, rejection, lack of industry or autonomy. This group is pretty industrious and like to make things happen on their own, so hospital setting is not very conducive to that. Being alone and fear of the unknown, and there's a lot of that here in the hospital. All right, and our last group we're going to touch on are the adolescent population. These are Lane's kiddos. So does anyone remember, this is Piaget's last stage. Anyone have any idea what that's called? Think back, child development. What could that be? This
Independence?
is, that's
No.
Emerson.
Get out of my room.
Piaget. That close enough. This is concrete operations.
Get out of my room.
So this is the concrete operational phase, and we are seeing theoretical and hypothetical thinking at this point, abstract logic. They're able to take information out of context. So if they learn one thing, they can apply it to something else, which is something that is useful here in the hospital for everyone to know. They might have experienced something tough at home or something tricky at school, and they can apply what they use to cope there to this procedure or this experience here. And strategy and planning become important. So preparation is really, really crucial for this adolescent population. And some things that they're afraid of: loss of autonomy, compromised body image. This is huge. Are upstairs on the units, especially kids that are here for a long time or have undergone a trauma or maybe lose a limb for whatever reason. Child Life is working with them constantly on improving their coping skills around compromised body image or any kind of disfigurement in general. Illness and death, super scary. Missing out, fear of missing out, FOMO is huge with this adolescent group. They don't want to miss anything. Rejection, expressing their emotions. This group does not want to be vulnerable. They're the too cool for school. I get it. I'm too tough. I'm fine here. Inside, they're not fine. Inside, they have questions, but they kind of have a block up, and we need to figure out how to get them to feel comfortable expressing themselves. An invasion of privacy. Those are things that are super important, super fearful for our adolescent group. Okay, can you guys throw out some things that you see, how you see fear and anxiety manifest themselves in the ED, like physiological symptoms, or how do you guys see fear show up here? Tantrums,
Crying, yeah.
crying, screaming, yeah, kicking,
Running down the hallway.
running down the hallway, yes,
Biting.
Somersaults off the
yep,
bed.
spitting, all those things,
Uncooperative.
uncooperative, yep. Increased heart rate, dilated pupils, respiratory rate gets increased, sweating, those things we see all the time.
Swearing.
Swearing, it's a good one, yes.
3-year-old
Swearing.
says things like,
So these are all responses to, these are all reactions to a flight, fight, or freeze. And you guys can come in if you'd like to. If you need to leave.
We're not really here.
I
We
get
wanna
it.
hear you.
I get it. Okay. So flight, fight, or freeze. I have a very scared dog on the screen from the little kitty here. And does anyone remember what is happening when fight or flight is happening in your body? Anyone have- Yes. You got sympathetic nervous system. So freeze, the freeze portion is being added by a lot of theorists now, but used to just be known as fight or flight. So what is happening essentially is our amygdala, which is like in our limbic, very ancestral lizard part of our brain, is noticing a threat, thinking something is a threat. Like let's say a car swerves at you coming down the street, and your amygdala says, "Whoa, not cool. I'm a little freaked out by this. What do you think, hypothalamus?" And hypothalamus, which is the memory center, says, "Yep, I know this is not a good thing. This car's coming at us. Let's let the pituitary gland know, that little tiny gland in the middle of the brain. Pituitary gland, arm the forces. The pituitary gland signals the adrenal glands, gets the adrenal cortical pathways going with a ton of acetylcholine and other hormones, and then the adrenal glands, hear them loud and clear, flood our system with norepinephrine and adrenaline, and then we get all these physiological responses that you guys were just talking about. So that's a little bit about fight or flight, and that's what's happening when those things that I listed before, those things that could happen in the emergency department causing fear. This is what's happening in the child or adolescent's body. So this is kind of another way to look at it. Very, very simplified, obviously. We have sensory input, so let's say someone jumps out and scares you like around the corner or something like that. The amygdala, alerts the hypothalamus, pituitary gland, adrenal glands, just like I said before. But your prefrontal cortex, because most of us are pretty functional adults at this point, says not actually a threat, cool it. And you have a very balanced response, and you're like, oof, okay, ooh, that was scary, but not actually scary. I don't need to fight or flee right now. So we have a balanced response. Or even something that's, is going to be painful or is scary, like let's say Susan from Employee Health is coming at you with your flu shot needle, and you're like, I don't really want to do this, but I have to do this. Prefrontal cortex says, calm down, we need this, it's important. It's going to hurt for a second, we'll be fine. And you have a balanced response. So now the second line here, pretend you're a child, your prefrontal cortex is not that mature, it's not that well developed yet. Or you're a child who is a frequent flyer in the hospital, and you've had a lot of stressful events happen, whether that's in the home or in the hospital, and you've got these really, really well-developed buff pathways between your amygdala and your hypothalamus and the memory center that's saying, like, these places are scary, these things are scary. And those pathways are actually stronger than the pathways that are developing between the amygdala and the prefrontal cortex. So that's the more buff the pathways between the amygdala and hypothalamus are going to win over. And these kids are having really unbalanced responses to hospitalization or emergency room visits. And that's where you're seeing these kids where you're like, why are they freaking out? We're not even doing anything yet. Or I can't believe like this 10-year-old is losing it. I'm trying to just get this quick line in. They know it's going to last 1 second. They've done this before. The problem is they've done it before and they've not coped well, and they've got these really, really strong neural pathways in their brain that kind of just negates the prefrontal cortex trying to calm them down. So what can we do to help these kids that are really, really losing it? I have these handouts. I'm not going to go through this whole slide because there's a ton of words up here, but I wanted just to pass this out to you guys. It's a really neat explanation for teens and kids and parents to know sort of what's happening in the brain. And it's sort of what I just talked about. We have this really jumpy superhero amygdala that is really important. It protects us. It saves us. It keeps us safe. But it needs to work in unison with the smart prefrontal cortex and the hippocampus. And I think I was saying hypothalamus and hippocampus. Just so you know.
Okay. We caught that.
Yes, thank you. All right, so, oh man, I don't know if this is going to work too. Oh, actually, we can watch this one because it's still funny to watch. So this is an example of flight.
Oh, that sounds working.
Yeah.
Shadow.
So this girl, she's seeing her shadow, and her prefrontal cortex, not there yet. She is fleeing, she's totally freaked out. She's having a really, really inappropriate response to something that's fearful, which is totally typical and normal and healthy at that age to have that response to something that's novel and scary. And a lot of that happens here in the hospital. So I want to jump into some strategies that we can use here, and what you guys already use to help you. Does anyone have any kind of go-to tricks or tips that they already use that help maybe make a child feel more calm, or that help parents feel more calm? Any ways that you go about starting your interactions with patients and families?
Singing.
Singing, yes. And you do some tapping too, Marie, don't you?
I do.
Tapping is a really cool.
Tapping on the
Yeah.
forehead.
Tapping on the forehead.
Oh, I
is
thought that was
very,
meant to
really
be
good.
tap dancing.
Yeah, I wish you tap dance, that'd be great. Anyone else have any go-tos that you would like to share with anybody? I'm gonna give some examples too. Okay, I'll jump.
Breathing.
Breathing, great. Encouraging people to breathe, showing how you take deep breaths, being that good example, very important. All right, so that is Gray. That's Talia's little girl. Mm-hmm.
She looks so like
She's so cute, and she's got such a little stinker face
Yeah.
in that picture. Okay. So, things to help infants. Some of this stuff, guys, might seem so basic and so simple, like you know it. You might not do it all the time. It makes a huge difference. And I try to throw in things that are not going to throw you out of your routine, that are going to allow you to get your work done, because I know that is the goal here for sure. But these little tips and tricks will help you get your work done faster. So, using a soothing and soft voice sounds simple, and most people in this room are actually excellent with this. I would say that people who made an effort to be here know the power of this stuff, which is really important. This does not always happen. Soft, soothing voice, you would think that's really basic. I get to hear and see everybody when I go into rooms and procedures with residents, doctors, and nurses. I don't always see a soft, soothing voice, and that's really hard for infants. Asking caregivers to speak or sing to their patient. This is so important. Hearing a parent's voice or a parent's touch automatically reduces the level of cortisol in a child's body, and it's the parent touch specifically. So encouraging the parents to maybe massage the child's feet while you put in your line, or sing them a song, or tell them a story, or tell them about their day. If they're like, I don't know what to say, tell us how your day went. Just talk. That's so important, and a great little tip. Encourage a comfort item. So if they may have a pacifier in their diaper bag, or they're afraid to get their blankie out because they don't know if it's okay, encourage them to do that. It's going to help the infant. Encourage some playtime for normalization. If there is a few minutes before you, while you're gathering your supplies or doing something, you can say, hey, do you guys want to read a story, or do you have any toys with you? Maybe you could play for a couple minutes. Giving the parents the kind of the opportunity to do that, or encouraging them to do that, is really helpful, because they don't always think of it, or they don't always know. They're stressed. This is a scary thing. Their child's not well. And bringing them back to those basic things will help. Helping family maintain a routine, especially if they're in the emergency department for a really long time. It's very important in distraction. Always good with this group. Oh, 5 S's. Does anyone remember the 5 S's? This is, like, if you have an infant, you've probably heard about them. You guys probably know. Swing, shushing, swaddle.
Shushing?
Shushing. Shushing is side position and sucking. So pacifiers, things like that. Even sucking on parent's finger while this is happening is important. Starting an IV while the child's lying on their side is going to be a lot less threatening for the child than having them lie on their back. And you can still hold the patient appropriately, especially a little one like this, with them on their side, rather than flat out on their back, which is such a vulnerable position. All right, toddler preschool. So this group, simple and concrete language, so important. Warm up with something fun. So while you're getting your tray set up, ask them about their favorite color, or if they have a pet at home, or what they were for Halloween. Those little questions make a huge difference. Provide some step-by-step instructions, really basic step-by-step. First, we're gonna sit on the bed. Next, I'm gonna put the rubber band on and clean with some soap. You're gonna take some deep breaths with mom and dad, and I'm gonna give you a pinch, and we'll have a straw, something like that. Give the parents and the patient a job. This is so important. I put PFC, that's Positions for Comfort, which we'll talk about. You guys have probably heard about that before. But instructing the parents to have a job and giving them something to focus on is automatically brings the parent's stress level down, because they have something that they can do and something that's going to help their child. And as soon as the parent is experiencing less stress, the child will experience less stress. That's something the child is picking up on in the room. So helping the whole family cope is important. Explain how things will taste, feel, smell, and sound. So all the senses are important here. Allow time for questions. This is one that sounds basic, but it does not happen. We never say, do you have any questions? Before we start a preschooler's IV. It doesn't happen, but they often do, and they often will say, wait, but what's that blue thing, or what's, and they might ask a silly question. Yeah.
What's the best response to will it hurt?
Be honest, be so honest. It sounds scary, and we're gonna talk a little bit about,
But like pain is so subjective,
yes.
and so it's one
Just
kid might say
yes.
a lot, and one kid.
I usually say most kids tell me it feels like a big pinch, and then it's done. Something like that. So it's, you have to be honest, because lying to a child is definitely the wrong way to go here. That's a really tough question, especially at this age, because as soon as they hear it's gonna hurt, they're gonna freak out, right? And that's what you're afraid of. Or parents might say, don't tell them, let's just do it, let's just be sneaky about it, which is not helping. I'm gonna talk to you a little bit about why that's not helping in a second. But being honest but tasteful about your language, we're gonna talk about some language consideration at the end here. Give real choices, not choices that do not exist. So you can say things like, if you've seen a good vein on both hands and you know that both hands are an option, which hand would you like me to use? Or would you like to, would you like to color one more page while I get set up? Something like that. So we're giving choices, not offering choices that are not real. So not, would you like to sit on the bed? If that's not an option, if they need to be sitting on the bed. Those sort of things. You guys are really good at that. I don't see too much of that happening here. I see parents actually offering bad choices all the time, but not so much staff. Promoting family-centered care and acknowledging success. So if the child it's like the blood draw was a disaster. They really did not cope well, but they were able to take 2 deep breaths with you. That is a success, and that's something that we can acknowledge. Or maybe they're screaming, and the only thing that you can pull out of it that was positive is that they were able to show you how they felt. And that is a positive thing that they got out of it, and you can acknowledge that.
Expressing your
You
emotions,
told us how you
screaming
felt, and
child.
thank you for that. Yeah, which sounds silly, but pulling something positive out of the relationship and the interaction is really going to help them cope later on. So our school agers, these Carrie and Chris's kids. Okay, concrete language, still with this group, we're not really in all that abstract thinking quite yet. So very concrete. Explain why things are happening and using examples. So we're going to take your blood and let's get started. We're going to take your blood because we have to test it to make sure that we want to figure out what's making you sick. Or we have to give you this little special straw because we're going to give you this bag of water that's going to make you feel better, or this medicine that's going to make your stomach ache go away. So not only are you explaining what you're going to do, but why you're doing it. Promoting family-centered care and leaving time for questions. Providing choices. Develop a coping plan with this age group. I always do that when I'm part of the team, but you guys can do that too. So asking them what's going to help them, or telling them that they're going to take a couple deep breaths, or telling them we're going to sing ABCs 3 times, that kind of thing. You're developing a coping plan with them, and having family involved in that is very helpful. Allow exploration of medical equipment. So let them touch the rubber band before you put it on their arm if they want to. Let them look at the tubes that you're going to put their blood into. Let them read the label on the medication. Little things like that, and allowing them to be part of that and explore it is going to help them feel more calm. And debrief and applaud their mastery. So whatever went well, like I said, same as the preschool toddler group, applaud them for doing well, whatever it was. And debrief. You can say, acknowledge and validate those feelings. That was hard. I know that hurt. You did a really nice job holding still. This was really, really hard, but I think this is really going to help us know what's wrong with your body. So you're debriefing with them, telling them why we had to do it, sort of thing. Anticipated stress is always easier to cope with than unanticipated stress. So this is what I was referring to when I was saying that a lot of parents are like, just do it, let's be sneaky, don't tell them. It'll be easier if we don't tell them. With our school age group, we need to tell them what's going to happen before we do it. It can be right before, that's okay. It doesn't have to be much long before the procedure or whatever's going to happen. But even if they're going to freak out before, and even if they're going to freak out during the procedure, the fact that we were truthful and attempted to prepare them or told them what was coming is going to help them develop a more trusting relationship with their caregivers and with staff here. So always important to tell them what's coming. No sneak attacks on school-age kids. In our last group, our adolescent group, do you guys have any questions so far? I'm going fast. Okay. So include patient and medical decisions. This is often, nurses do a really good job at this. This does not always happen with the other medical team members, doctors, residents. I see them talking over this adolescent group like they would a small child, and this group is very much a part of a medical decision. It's their body, they're autonomous, they're independent, they need to be part of that decision-making process. Encourage questions. Remember, this is our group that's pretty afraid of being vulnerable, so encouraging them to ask questions or anticipating misconceptions that they might have, or fears. Like most of you all do this, the needle will come out, so the needle's already out. That's a very common misconception with an IV, and something that a teen's probably not gonna ask you because they're afraid. Some might, but they don't feel comfortable always letting us know that they are scared or how they're feeling, so letting them know what's going on and anticipating those fears. Respecting them as separate from their parents. This group is, they're big kids. They have their own little lives. Obviously their parents are still involved in the medical decisions and will make them for them, but teens need to be recognized as separate and recognized as having maybe different feelings about their medical care than their parents have. And ask what will make them cope, what will help them cope. So a lot of times our adolescent group might lay still and be cooperative for a procedure, but they would have done even better if they could have just listened to their music, and they have their headphones and their phone right next to them, but they didn't know it was okay to do that. So saying, is there anything that would help you feel more relaxed or more comfortable during this? And they might say, or you could throw out some examples. Do you want to listen to music? Do you want to hold mom's hand? Do you want to think about something else? Do you want to talk while we're doing this? Giving them some suggestions for coping. They usually will grab onto something, and that will help this group because they might not know to do that on their own. And ensuring privacy and letting them know that we respect their privacy the whole time they're here, especially with their bodies, is going to help them feel less fearful. So just wrapping up, I got a couple general tips for success. These are sort of fun. Language considerations, IV or IV. This is a tricky one. So starting an IV, most people who have not had one before can only think of the plant IV, which is very tricky. A CAT scan or a CAT in a fax machine, like a CAT scanner. I know we say CT most often, but that's a very common misconception. A flush or a flush. If you tell a child you're going to flush their line, a small child, they are absolutely thinking you're putting something down the toilet. Like, this is really confusing. Flushing your line is one that I hear all the time, we use all the time, and it's not common lingo for them, and they are going to think toilet for sure. Drawing blood or drawing blood. I hear everyone say, I'm going to draw your blood. That means you're going to scribble with a red crayon. Like, that's what it means to a child. So very, very confusing. So being really explicit and very careful about your language, very thoughtful about how we explain things, and kind of jumping ahead of the child and knowing what they might.
Taking your blood is equally as tough.
Taking your blood, yeah, that's a tough one.
I'm going to take your vital signs.
Yeah.
No, you're not.
Right, taking anything. Or I'm going to give you medicine to put you asleep. The only experience they've had with things being put to sleep are their animals dying. So being put to sleep is not something you want to say around here. Helping you, this medicine's going to help you take a quick nap so you feel no pokes or pain, is something how we would rephrase that. And then cast saws, those are tricky. The saw is going to cut your cast or cut your, like, that's very scary. And then incisions, talking about incisions, we're going to cut you open. Instead of saying we're going to make a small opening, cut you open is very scary. And that's what we hear most often around here. And then, will it hurt? And this is where I was going to talk a little bit about this. It is so important to be honest but very tasteful about your language here. And it is going to hurt. We want to tell them that. Okay. We can say most kids tell me that it feels like this, or maybe when we're done you can tell me how it felt for you, and allowing them to sort of be more interactive and more thoughtful about the experience themselves. Positions for comfort. This is just one of many positions for comfort. This is actually like a whole nother presentation that we can do. Most of our staff here, some are really, really into using this. This one is called chest to chest, but most here prefer children to be laying in a bed for procedures, which a lot of times has to happen, and that is, we need to get things done and we have to be safe about it. But there are times where positions for comfort can really, really help patients and parents cope with this experience. So this one's called chest to chest. So you can see in the middle there with the red circle, mom is hugging her child tightly. The child's legs are wrapped around her waist. The child life specialist or someone is providing distraction in the other direction. We have a nurse or someone helping to hold the patient's arm while someone started an IV or drew some blood. The physical touch from the parents is ultra soothing for patients, even though it's still going to be hard. It's not going to be an easy experience. It will help their ability to regulate their emotions. Okay? And there are about 5 or 6 really well-known positions for comfort that I have posters for. They're really outdated here at this hospital. We're working on updating those so you can pick those from. But if you have questions, let me know. And then this is the last thing I want to touch on today. Have you guys heard of this concept, one voice? You guys heard of this? It's sort of it's like a movement more than anything. I worked at Children's Hospital, Comer Children's Hospital at the University of Chicago, which is a level 1 trauma center just like this one, very similar demographic. And one voice was incredibly incorporated into the emergency department. And this is like kind of an idea that when you're in a procedure or in something stressful, only one person is speaking to the child. And this is not done here yet. Having one voice coming at the child helps them process what's happening, actually hear what's happening. We see when all these voices are coming at them, especially like in a trauma bay or something, that children actually check out because there's too much stimulation. They can't actually focus on one thing, or there's too many people trying to provide distraction. And everyone's doing it for the right reason, or everyone's trying to help the patient calm down. Maybe the parent's talking to them, or both parents are talking, and the nurse is talking, and the volunteer that's holding is talking to the child. And everyone's like, it's okay, we got this, you got this, you're okay, it doesn't hurt, we're almost done. It's so overwhelming. Having one voice coming at the child and having a plan for how that looks is definitely the way to go to help children cope better. And that usually, if child life is not present especially, is the parent speaking to the child, so parent involvement is really important here. But maybe the parent's not that comfortable, or the parent's really nervous, and you notice that they might be better at massaging toes, or holding the patient tight, or holding a hand. And maybe you're, as the nurse, is the better voice coming at the child because you can provide a soothing voice and tell them what's happening. This is kind of where I see things going. When in the trauma bays at Comer, child life would be at the head of the bed in every trauma. We cover 24/7 there, so this was an option. So child life's at the head of the bed. The room is filled with clinicians, and the child life specialist is the only person in that room that is allowed to talk to the child. And that's how it goes across the board in all the trauma rooms there. And the medical team is asking questions through the child life specialist, and the child life specialists are very much a part of the team. They know what questions are coming. They know what to ask the child as far as responses that the team will need. So this is very much part of the trauma exam. And the child and the clinicians are still talking to each other because that obviously needs to happen. They're letting the charting nurse know what's going on. There's still noise in the room, but as far as the noise that's coming at the child, it is one voice. It's a voice they hear throughout their exam, and it's a soothing and it's a calm one. But the exam still happens just like it's supposed to. The questions are still asked, and not only are you asking those questions, but you're also providing comfort. Maybe you're singing a song, or talking about their day, or telling them that mom and dad are sitting right here because they can't see mom and dad. Things like that. So. Very, very important and very, very much part of emergency departments and hospital experiences across the country now. And I have a little, hopefully this video will work because this one's actually really neat to see. It's pretty quiet though. You'll get the point. This is a real procedure. This is actually happening. So the nurse is not speaking to the child, the parent's not speaking to the child. So this child is coping much better with the experience. Just the child life specialist in this video is speaking to this child. And it's helping them process what's going on, it's helping them understand, it's helping them actually engage in the distraction, which this child in the previous clip could not. There was too much happening. So that is the end of my presentation. Are there any questions or anything you guys want to add or, yeah?
What did you say that EFC stood for?
Positions for comfort. That was that whole, that was
And can you put up the slide, the one voice slide of it?
yeah, absolutely.
Maddie, I'd like to see a policy about that. I mean, like,
Yeah.
because you know I have to be able to bring everyone under the moon.
Yep.
Because otherwise I'll be one voice.
I get it, I get it. No problem.
So that would be great.
Yeah.
Excellent. You know what, bringing us back to growth and development and stuff is really important. Appreciate it.
Absolutely.
So you said there were a bunch of different positions other than holding them on the,
Yeah.
what were some of the other ones?
So there's back to chest, so that's where the child's facing out and the parent is holding the child with their legs wrapped over the child's legs. There's where the child is laying down and the parent has their hand over the child and their parent's face is right in front of the child's face.
Okay.
There's 5. I can bring a poster
Okay.
down, we have them
Okay.
upstairs. They're from like the 80s, they're black and white, they're really outdated, but there's something, yeah, exactly.
Yeah.
Yeah, that's a good, it definitely helps regulate the child's emotions for sure.
Okay. Thank you.
Anyone else, questions, thoughts, concerns? Everyone who is here can get some bubbles. To take with you.
This is like
Some
way off
stickers.
topic here.
Yeah.
When you were showing the FTE and all that, are you considered 4/5 then, so you're part-time
I consider myself full-time in this.
in this scenario, so, okay.
Yeah. So there's,
Hello. Okay, I felt fearful just then.
yes. We approve of purpose.
Yes, I had a little thing.
Totally
on that.
expected.
She expected it. Not afraid. So, okay, but then on the, because I got asked this pretty recently,
Yes.
like Monday. Who covers when you're not here? No one, so we don't extend the care except for home care. So kids win the lotto on the day you're here, that's great. And the rest of us can, of course, do the best we can, but we're also the child life person and the poker.
Absolutely.
Yeah.
Which is very.
And the worst parent on the planet says if you don't behave, you're gonna get a shot.
Uh-huh.
And